You do nothing in the chat. We can't, unfortunately. We've got to finish our slide deck from yesterday, and we've got to start a new slide deck. And in case you guys are wondering, because you may wonder, you may not, the test. I know, I just said the test is combined with cardiology, so it's not a standalone test. So that may be beneficial for some. Some of you may not, most of you probably don't really care. But it's always sucks to have one test in one class and then pray to God that it all turns out right. So instead of praying so much, we're going to actually learn a bunch of stuff in cardiology and maybe pass that. We have a total of 9 classes that we'll go through. The last 2 are pretty quick classes. But today we've got to finish up our slide deck from yesterday, just a few slides, and then we've got to talk about some more basics. So before we get into the meat of what is this rhythm, we still have to talk about some more basic stuff. So you know about the key waves, so we're going to review that, key wave, as well as complex. But we're going to review some other things that we haven't talked about as well. And then our next lecture, we're going to start getting like, how do we determine the weight? What is this crazy rhythm that this person's in that I'm seeing on this ECG? So EKG lead placement. Okay? And remember, we have those 10 electrodes. We have limb leads, okay, which are going to go on the limbs. And where you place them, so a long time ago, back when I was a PA student, which was truly a long time ago, the more I sit in an office with people like Lieutenant Lyman, who's 20, and I'm telling these stories, people are like, how old are you? And I'm like, really? Like, you know, I know where you live, right? Nothing like that. But EKG lead placement nowadays, for the electrodes, they typically are going to come here, like in the joint area, just medial to the humeral head. And then on the hip area, okay? Again, you try not to put it over the bony area because it doesn't conduct all that well. Previously, we put it all the way down on the arms, all the way down the lower legs. Why? Anybody have an idea why? The same reason why we have that extra lead, just because it interferes. The EKG machines weren't that great. Okay? Now they're a lot better of being able to internally reduce the amount of interference that we have. So we used to put them all the way down, but they realize you don't really need to. But you can do that. You know, let's say, you know, you're seeing somebody, you got to get an EKG done really quickly on them. They have long pants on them. They have a belt that's really tight. You can throw leads down here at the bottom of the feet, throw leads here. You don't have to rip off all the clothes and just specifically put these leads on. Okay? So here's how we're going to put those leads. We've got our limb leads, and you guys are really lucky because, again, nowadays those ECG machines tell you RA, LA, LL, RL, right leg, left leg, right arm. That's on the wires that are going to hook up to the electrodes, and we're going to put those on. Okay? That being said, do people still screw it up? Yes, they do. And so it's going to be your medics, unfortunately. And you're going to train your medics, and you're going to show them a million times how to do it, and they're going to bring an EKG to you. It looks like the patient is dead, and you're going to like, let's go back to this again and how to hook up these leads. Okay? And then the precordial leads, those chest leads, we talked about how those go. V1, V2, 4th and 5th intercostal spaces. Those are the only intercostal spaces we're using, but it's whether it's next to the sternum, mid-axillary, mid-clavicular, anterior axillary. Those are the different places for your chest leads and your precordial leads. This is a regional map. I would commit this to memory, not only for us here, not only for cardiology and EKG, this is for life, that you have to commit this to memory. If I'm looking and I see something is awry in lead 1, I'm like, okay, I remember lead 1 with upright P, maybe a little Q, we come up for our S is down here, we have our ST segment, and then upright T. But it doesn't look like that. I need to know what part of the heart that's looking at. And that's what this regional map tells you. 1, AVL, 5 and 6, they're looking at the lateral side of the heart, the left lateral side. Okay? 1 and AVL kind of give us the higher part of that left ventricle, and then 5 and 6 look at the lower part. 2, 3, and AVL, those are looking up at the heart, the inferior portion of the heart. Okay, we've got AVR. AVR stands alone. Remember, that's the only lead that looks different from the rest of them, opposite of everything we talked about. And that looks a little bit of, there's nothing, none of these leads look directly at the right side of the heart. None of them. The closest we get, though, is AVR. Okay? And then it also looks at a little bit of the upper portion of the septum. V1, V2, septum. Okay? 3, 4, anterior. Gotta know this. What looks at the back of the heart, the posterior part of the heart? None of these. None of these. We have to put leads on the back of the person to look at the back of the heart. But B1 and B2 will give us an indication about posterior, something going on in the back part of the heart, the posterior part of the heart. And we'll talk about that in another lecture. But you've got to commit this, and then you'll have many questions on this type of thing. This is what a normal sinus rhythm looks like. So we look at 1, 2, 3, AVL, AVF, and V1 all the way through V6. And look at your P, Q, R, S, T pattern. Upright P. Most of these, we don't really see a Q. We've got a little bit of Q here in 3, a little bit here in AVF, and that's really, so 3. So not a lot of Q, and I told you a lot of times we're not going to see a Q, so it's not unusual not to see a Q. But otherwise we have that RS, we have a little bit of S, we got our T, okay? And that's what we expect. That's what we expect to see. And then we look at AVR. AVR, we've got that inverted P, we've got that down going R instead of up going. We've got that inverted T, same thing that we talked about yesterday. And when we look at how our R waves are spread apart, they seem to be pretty even if we were to count the box from top of one R wave to the top of another R wave. The other thing I want to point out is look at those precordial leads. Yesterday we talked about in those precordial leads that R to S change. Okay? R to S change. In V1, we normally are going to have a very small R with a pretty prominent S. Do we see that? Yes. First deflection after that PR segment is an R, little tiny R, but look at that big S. That's what because we're away from the left ventricle. We're overlining the right ventricle. Okay, look at V2. V2, little bit more prominent R, but still much more prominent S. Then we get to V3, and we're kind of above and below that baseline about the same. That transition usually does occur between V3 and V4, so we're going to see that transition. We're kind of equal with our R wave and S wave. V4, more prominent R wave than S. V5, we really don't have much of an S wave, and then V6, not much of an S wave. And that is a normal progression that we're going to see. There are things that are going to change that progression. Okay? If we have a change in axis, if we have hypertrophy, some of that will have a change in that progression that we'll talk about in other lectures. Okay? Where is the pacemaker of the heart located? Right atrium, right? Right atrium. And that's from your freshman semester. So we know that the SA node, as long as the heart is functioning correctly, then we're going to have it up in the right atrium. All right, let me see here. Redolin? Where are you? Okay, ma'am. Which precordial lead is located in the 5th intercostal mid-axillary line? V6. Everybody agree? Yes, V6. Very good, very good. Okay, don't forget, when we look at it, you ready? You want some? And don't forget that we talked about depolarization towards a positive electrode. It's going to be positive, positive. It's going to be upright. Depolarization towards a negative is going to be down going, and then repolarization, negative plus a negative to positive, and then if it's perpendicular, it kind of goes down, up, and then back down to baseline. This is just talking about ECG lead placement. Okay, we've got our right arm, left arm. Down here at the hip area, we've got our left leg, and then that right leg is specifically for interference. Okay, and we've got our precordial chest leads, and all of those are in this equilateral triangle, and so they all communicate and can see different portions of the heart. All right, you've got a 75-year-old male coming in, heart lead. Okay, sir. 75-year-old male coming in, chest pain. EKG says there's changes in 2, 3, and AVF. What part of the heart are we looking at? There you go. You're wrong. Still get candy. Anybody have a different guess? Inferior, right? So I say 2, 3, and AVF, they go together. F is inferior, so you can kind of think about it that way. Okay. Well, what you said, delta. So now that you're reconsidering, what leads you think go to delta? What are those lateral leads? AVL, right? Because L, lateral, left. Yep. 1, AVL, V5, V6. And 1 AVL, 5, and 6 are going to give us that lateral portion of the heart. All right, and that's it for our class from yesterday. Not today. Yesterday. Okay. EKG basics. EKG basics. We're going to continue on with some basics before we can go on to actually reading these EKGs. Our TLOs and our ELOs. When we think about limb leads. How do you say it? Kai Raphael? Not here. Okay, side. Okay, ma'am. Which of the following are limb leads? Alpha, Bravo, Echo. Okay, because lead 1, lead 2, and then AVL. Is AFV? Is that America's Funniest Home Video? Yeah, that's not part. And then we don't have a lead 4, right? We have a V4, but we don't have a lead 4. And it's important to know the difference. Very good. Okay. And what about, let me see here, Morris. Okay, sir. What's located in the 5th intercostal space, mid-clavicular? What'd you get? Always go with your first guess, right? Always go with your first. V4. Does anybody agree with that? Yeah, V4, right? Because V5 is going to be anterior axillary, and then V6 is going to be mid-axillary as we go across. Remember, you're going to put V1, V2, you're going to skip V3, you're going to go to V4. Once you place V3, V4, you'll go back and place V3. All right. Okay, now we've got a 72-year-old. Oh, this should be pretty easy for Bandy. Bandy. Okay, yes, ma'am. Okay, 72-year-old coming in, EKG, so it's ST elevation. V5, V6, 1 in AVL. What's going on? What part of the heart are we concerned about?
ST, we're concerned about V5 and 6. Oh, we just talked about it, yeah.
It is not. Lateral 1. So the 1, ABL, 5 and 6, right? 1, ABL, 5 and 6. Just think that L as lateral, even though it's left, so left lateral. All right. Very good. Okay, it's all right. It's going to be okay. All right, we talked about that. We've got our limb leads. Okay, we've got our limb leads. We've got our ABR. We've got our ABL. ABR is up on the right. ABL looking to the left. And 1. Okay, we already know 5 and 6 are also looking at the left. And we got 2, 3, and ABS. That's looking at the inferior portion of the heart. Here we put that together with our precordial leads, or our chest leads. Because remember that the limb leads look at the frontal part of the heart, and the precordial leads look at the horizontal, so it looks through the heart. So V1 and V2 is going to look at the septum, V3, V4, anterior portion of the heart, and then 5 and 6 is going to look at the lateral portion of the heart. The EKG paper, we know it's a grid paper. Okay? And the majority of the time, the EKG is set to run paper under pen at 25 millimeters per second. It's our standard unless you change that for some reason. And you can change it. You can do up to 50 millimeters per second, especially if you want to slow down the rate. So if someone comes in, palpitations, you'll feel their pulse and you know, it's 200. You won't be able to see anything on the EKG except for this, right? So we're trying to figure out what's going on. We can slow that rate down, give us a little bit better idea. If we can even figure out, is this regular, is this irregular, we can just see that it's fast. But normally, when we just do a regular EKG, we don't touch any settings, it's going to be set at 25 millimeters per second under the pen. When we are reading these EKGs, the horizontal axis, and going across this way, is time. How much time has elapsed? Remember that each little section, V1, V2, V3, all the way to V6, each little section gives us 2.5 seconds, a snapshot of 2.5 seconds of what's going on in the heart. And then that bottom lead, usually lead 2, okay, a rhythm strip is going to give us 10 seconds. And that's all identified on the horizontal axis. The vertical axis is our amplitude, meaning how much electroactivity is going towards that electrode. Will be high, if it's a higher amount of electroactivity, you're going to have higher amperage, higher voltage is what's going to be seen usually in our R wave, or even downward in our S wave. So along that horizontal axis, we have big boxes and we have small boxes. Does everybody see big boxes and small boxes? The big boxes are kind of a darker red, and the small boxes are a lighter red. So that small box equals 0.04 seconds, okay, 0.04 seconds, or 40 milliseconds, right? The large box is 0.20 seconds, which means that the large box is made up of 5 small boxes, because 5 times 4 is 20. Okay? So 5 small boxes for 1 large box. Okay? Now, on that vertical axis, that's that amplitude, how much energy is going towards that electrode. 1 small box is 1 millimeter, and 1 large box is 5 millimeters. Each lead is going to have a different amount of amperage. So if you look at that V1 versus lead 1 versus V6 versus lead 2, each R wave or QRS complex is going to have a different amplitude. But there are still certain parameters that we'd like to see those R waves in. We don't want to see R waves that are 45 millimeters in height, because that indicates we have a lot of electroactivity going towards that electrode for some reason. On this bottom picture, in order for us to count the total voltage or the amplitude, we're going to start at our baseline. Remember, our baseline is going to be our PR segment. You start at that baseline and you count how many boxes. So I know I have 1 big box here, so I know that's 5 small boxes, so that'd be 5 millimeters. I know I have another big box here that's 10, and And then how many small boxes do I have? 1, 2, 3, 4. So this should be considered of having an amperage or a voltage of 14 millimeters. Okay, that's how we do this. It becomes really important when we're assessing for things like hypertrophy. At the bottom of your EKG paper, okay, I'm going to blow this up for you. The bottom of that EKG paper is going to tell you what your speed is set to for that specific EKG machine. Okay. So if this one says 25 millimeters per second, great, because that's what we want. That's our standard EKG machine setup, and that's exactly what we want. It also says that your limb leads, 10 millivolts, so 2 big boxes is equal to your chest leads, right? So those are equal to 10 millivolts, so that's 2 big boxes, right? So 1 millivolt equals 1 millimeter. If you have 10 of those, that's 2 big boxes. And then this is just internal stuff for the EKG machine and what the hertz is for the EKG machine. So you don't typically have to worry about that. The biggest thing you look at is the speed, and then what is your limb and chest lead. They should be equal. There are some tools that you should consider getting or purchasing before you go to phase 2. Can't really use them here, but in phase 2 you can use them. Calipers. Calipers are really important because I remember, so I went to phase 2 at Fort Campbell, which was absolutely amazing. And we read tons and tons and tons of EKGs, so those calipers came in handy because you're reading a lot of EKGs. The EKG ruler has a lot of different information. It has this information about what your EKG speed should be, or what is your voltage, or what is the normal QRS complex width. It has all that information on that ruler. And then the axis wheel ruler is important. We talk about axis and identifying the axis. This has different numbers on it to remind you of what is left axis deviation, what is right axis deviation, what are the parameters associated with that. So again, you don't need to get that stuff here, but it might be beneficial depending on where you're going for your phase 2. We've got a lot of different waves and intervals and segments that we're going to see and need to know how to interpret on these ECGs. Again, we've talked already about some of these. We talked about P wave and PR segment, but there's a lot of these we still need to talk about. So we're going to review some of the stuff we talked about, and then we're going to add some new information for these waves, intervals, and segments as well. You also need to understand wave nomenclature. Okay, so if you're reading in your free time from midnight to 4, then you may see, wait a minute, it says something about R prime. What the heck is that? What are they talking about? Why do I have a capital letter and a lowercase letter? What does all that mean? Well, this is what this means. Okay? Normal wave nomenclature, we've got our P, we may have a little bit of a Q, we've got our R, we've got a little bit of an S, we've got our T. That's normal. Sometimes, or remember that this P wave indicates depolarization of both the left and right atrium, right? Well, the R wave indicates depolarization of the left and right ventricle. So if there's something going on and they are not depolarizing almost simultaneously, we're going to see that by a split up of that R wave, okay? Or maybe even a split of that S wave. So if I had an S wave and it looked like I had 2 S waves, what part of the heart is that telling me there's some problem with? The ventricular basis, right? Ventricular basis. So we have this nomenclature. This is the R wave is the first positive inflection after your P wave. So if you come up, you come down, but not all the way down to baseline, and then you come back up. That's 2 R waves. There's something going on. There's something that's going on with the ventricles that is allowing you to see depolarization of both of those ventricles independently. Okay? And we name this R and R prime. R and R prime. That means I've got 2 R waves. For some reason, it's my job to figure out what the deal is. Now again, sometimes you'll have a capital R, sometimes you'll have a lowercase. Lowercase r just means it's a little r. Okay, capital means it's a big R. That's all the differences. I don't really care, you don't need to know that, because a lot of books don't use the differentiation, but like in Garcia does differentiate that way. We've got another big R and then little r. Again, the little r here, that's a lowercase r, and then a prominent R is the uppercase. What is the difference between this bottom one here and this top one here?
It goes below
Goes below the baseline. And once it goes below the baseline, that's no longer just an RR prime. Now it's an RS, and if you come back up above that baseline, that's another R, so that's your R prime. So it'd be RS R prime. And that tells us, if we just wrote that down, we know that we're starting up, we're coming all the way below the baseline, and then we're coming back up again, which is unusual. And then here, we have R, great, S, great. We come back up above the baseline again, and we go back below the baseline again. So we've got R prime, and S prime. This becomes important when we think about things like, anybody know what causes these?
Bundle branch block.
A bundle branch block. Bundle branch block, because now we have, instead of our ventricles depolarizing via the electrical conduction pathway, they're depolarizing myocyte to myocyte. Takes longer, and we can see that on our ECG. Here's an example of our RSR prime or RR prime. So again, we've got our P wave, we've got our first inflection after the P wave, which is our R wave. We come down below baseline, which is exactly what we expect, large S wave, but now we've gone back up above baseline again, so that's going to be RSR prime. All capital, all lowercase, I don't care, but just know it's RSR prime. This next one, okay, we think, is that an RR prime or RSR prime?
RSR.
It's RSR prime. What about this last one? That's RR, right? Because we're not coming down below baseline, we're just coming down a little bit and then going back up and then coming down the baseline. All right. That P wave, atrial depolarization. Okay? And that is going to be the first wave of on a normal ECG. The P wave duration is typically less than 0.12 seconds or 120 milliseconds. 3 small boxes. Okay? 3 small boxes. So if I tell you the duration is less than 3 small boxes, am I talking about in the horizontal fashion, or am I talking about vertical? Horizontal. Time is horizontal. Okay, so 3 small boxes going this way, going across the horizontal axis. And then the amplitude for the P wave is typically between 0.5 millimeters and 2.5 millimeters. So half of a small box all the way up to 2.5 small boxes. Not big boxes, that's 5. Half to 2.5 small boxes. And remember that the P wave represents depolarization of the right and left atrium. The right atrium is going to be seen first, and the left atrium is going to be seen after that. Typically, we're just going to have this round P wave. And we talked yesterday, it's round because it doesn't take as much electroactivity for the atria to depolarize. Okay? But if there's something going on with the atria, like atrial hypertrophy, let's say you had right atrial hypertrophy, what's going to pull more of that electroactivity, and we're going to see where the atria are depolarizing differently. Okay? We're going to see a little hump in there, or we're going to see a really peaked P wave on one area, and then the other one, the other side of the P wave is flat. And so if it's the first part of that P wave that's abnormal, that tells us there's something going on with the right atrium. If it's the latter part of that P wave, it's going to tell us something going on with the left atrium. Okay? We've got that PR segment. We know that PR segment is that slow depolarization through the AV node. It is measured from the end of the P wave to the beginning of that QRS complex. Now, a lot of people get really confused. What if I don't have a Q wave? Then it's to the RS complex. We typically still call it a QRS complex, okay? But whatever, it's either you've got that flat line, you're either going down Okay, if you just have an S, or you're going up. So whatever that next inflection is, whether it's a downward inflection or an upward inflection, that is the end of your PR segment. We know that it is considered our baseline. Now, meaning that everything that we're looking at, specifically when we think about ST segment, and then between our T and our next P, should all be in coordination with that PR segment. Sometimes it's normal to have a little bit of PR segment depression, up to 0.8 millimeters. And sometimes we can see that. That's just a normal variant for some people. Okay? Sometimes, especially if we see it diffusely, it indicates disease. Something like pericarditis can cause diffuse depression of that PR segment. So if it's greater than 0.8 millimeters, so 0.8 millimeters, how many boxes? Right. So one box is what? 1 millimeter. So not even a box, right? Just a little tiny bit. Little tiny bit. So but most of the time you won't even be able to see it. So if we have PR depression that's greater than 1 millimeter or so, we're thinking more like some underlying pathology as opposed to a normal variant. PR interval. PR interval measures the time it takes for depolarization, goes from the SA node, and we've got the atria that are depolarizing, and it goes all the way to the beginning of our QRS complex. That is our PR interval, from the beginning of the P wave to the beginning of our QRS complex. And it measures that atrial depolarization all the way to about the junctional area, and even a little bit through that junctional area. Normal duration of the PR interval, 0.12 to 0.20 seconds, okay, or 120 to 200 milliseconds. 3 to 5 small boxes. It can be prolonged, but usually, which can be a normal variant. A lot of times when we think about something prolonging that PR interval, we think about something like a block. The first degree AV block. Something's going on the AV node, and it's causing that time, usually at that PR segment area, is causing it to be longer than normal. Medications can change your PR interval. Okay? And again, it could be a normal variant. We like to see other EKGs to compare to. What is this patient presenting with? They're here for a flight physical. There's nothing wrong with them. Okay, maybe it's not a big deal. Maybe it's something they've had before. There's times that PR interval can be less than those 3 small boxes. Okay, meaning we've got depolarization that's going through the atria, through the AV node, quick. Something's causing it to be much quicker than it normally would be. Okay, something like an accelerated pathway or an accessory pathway. Okay, why is my conduction going really quick down to the AV node? Maybe we've got a congenital anomaly going on in the heart, and we're going to see that with that shortened PR interval. Again, sometimes it's normal. It's a normal variant. We can't go through all the different normal variants because we've never learned anything. Okay? But think about PR interval, 0.12 to 0.20 seconds, 3 to 5 small boxes, and if it's outside of those parameters, we're going to think it's abnormal. Okay? So here's some examples of PR intervals. We want that 0.12 to 0.20 seconds. We start at the P, we go all the way to the beginning of that QRS complex, and that is normal. Okay. This, we can see that our PR segment appears to be much longer. And we don't have little small boxes here, so we just have to trust what it says. But if we had small boxes, it would say this is greater than that 0.20. So 0.20, how many boxes is that? 5 boxes. 5 boxes, 0.20. Okay, and then here, look at how small, how short that PR segment is. Something is allowing that electrical activity to be conducted very quickly. So it's getting down to that AV node really quickly. And we'll see that by having a really short PR interval, which is less than 3 boxes. Q waves. Q waves can be bad, or they can be what we call insignificant. We have insignificant or significant Q waves. We know that it represents ventricular septal depolarization. We know that after the P wave, it's going to be our first negative deflection if we see a Q wave. Okay? In a normal Q wave is typically less than 0.5 0.04 seconds, so one small box. And less than 2 millimeters in height, or two small boxes in height. Okay, so we think about the width should not be wider than one small box, and it should not be deeper than two small boxes. Okay? Or, kind of a rule of thumb, is 1/3 of the height of the R wave. This is where calipers really come into play. Because you can measure with those calipers, you can measure that Q wave. And then you take those calipers, you gotta put on the paper like this, okay, and they're opened up. You leave this top one there, and then you flip them up. And then you flip them up. And if that's more, if your Q wave ends above that R wave, that's a problem. It's too deep. And other times, so Q waves in lead 3, AVR. What do we talk about AVR? AVR can have Q waves, right? Sometimes, but if it's greater than 2 millimeters, it can be normal in lead 3 and AVR. You can have small septal Q waves in your lateral leads, 1, AVL, V5, V6. Oftentimes, those are less than 2 millimeters. So here we have, so on this top one, we have small septal Q waves. We can see that's only about a box. And here, and then we've got here in 5 and 6 as well. We only see much in 5. I think they're just little tiny dipsels that go down, little small Q waves. Nothing to worry about with those. Here we have some normal Q waves. So look at our lateral leads. Look over here at V6. Okay, there's a small Q wave there. Do we see anything in 1? Little bit in 1. AVL, a little bit. So those lateral leads are primarily where you're going to see this. And we don't really see this. What about AVR? Okay, we really see this big R wave in AVR. So you don't really see much there, but just know that there are times that we're going to see these small ones, usually less than 2 small boxes deep and 1 small box wide. There's another picture right here. We've got a little small Q wave right here. Again, use your calipers. So significant or pathologic Q waves. We get concerned if someone has significant Q waves that they are infarcting, or it could indicate that they have had a prior MI. So when I see Q waves, I will talk to my patient. I'll say, "You ever had any problem with chest pain, or anybody ever tell you you had a heart attack before?" No. A lot of times they have no idea. Technically, might consider a silent MI. But most of the time, they weren't really silent. The patient just what? Didn't pay attention to the symptoms, right? Well, I do remember that one time I had chest pain for a little while, but after a few hours, it just went away. I felt okay, felt a little yucky for a couple of days, but I didn't come in because it went away. All right, so most of them are not silent, but it could indicate that they previously had an MI. Or it could indicate that they are infarcting right now. So 75-year-old comes in, they're clutching their chest, and we see Q waves, I'm going to assume that he's infarcting right now. Greater than 0.04 seconds. So if they're greater than in width, okay, that 1 small box, that's concerning. If they are greater than 2 millimeters deep in 2 contiguous leads. What do I mean about 2 contiguous leads? Those that look at the same part of the heart. Okay, so not V1, V2, V3, V4, not in line, it's V1 and V2 is contiguous. 2, 3, AVF is contiguous, right? They look at the same part of the heart. So if I'm seeing greater than 2 millimeters deep in contiguous leads, okay, that is concerning that this person is infarcting. More than 1/3 of the total height of that QRS, you get out those calipers, measure that QRS, flip them up again. If that Q wave is going above that R complex, then that means it's greater than 1/3 of the height. If we see them in V1 through V3, now V1, you might see a little bit. Typically, if they're greater than 2 millimeters, V1 through V3, that's very concerning that they may have an infarct. Oftentimes, these Q waves don't develop immediately. not, 5 or 10 minutes. We may see the ST segment changes immediately, but those Q waves often an hour or 2 hours after that patient started having their signs and symptoms. And they don't have to meet, the EKG doesn't have to meet all of these criteria. It can meet one of these criteria and still be concerning. You could just have, greater than 2 millimeters and 2 contiguous leads, and that right there is enough to say that this patient is probably infarcted. So here we have some abnormal Q waves. 2, 3, AVF. What leads are those looking at? Inferior portion of the heart. And anybody agree that those look a little shady? Because by parameters, greater than 2 millimeters. How many boxes? Well, that's at least 2 there, if not 3. Okay, here we've got almost an entire, almost 5 boxes there. Okay, a couple boxes here. So those are definitely concerning, especially, if a patient's presenting with chest pain. Okay. If they're not presenting with chest pain, this might indicate they had an old MI. Like, no, I'm just here for a routine evaluation. That might indicate. The other thing I want to see, because we haven't talked a tremendous about this yet, but you should still be able to recognize it. Okay? We talked about the ST segment. And we said that ST segment should be along the baseline, right? Should be along with our PR segment. What do you guys think about the ST segment in a couple of these? Okay, so let's just look here. I mean, we can even look here. Well, here's our P wave. Our PR segment's down here, so either that PR segment is really depressed, or this is elevated. Okay, let's look over here. We've got our P wave here, we've got our PR segment, okay, and we've got this round hump right here. Is the ST segment typically rounded, or is it typically flat? Because if it's rounded, that means we still have electrical activity that's occurring, and that's concerning. This person's actually having an active MI. Okay? And we can see that not only by the Q waves, by these changes here in V2, V3, V4, V5, V6. I mean, this person, inferior, we've got septal, we've got anterior, we've got some little bit of lateral changes. They're having a significant MI. And this time to phone a friend real quick. All right. So you do have to spend some time looking over the parameters for those Q waves. You must identify those abnormal Q waves. You will send these patients out of the clinic thinking it's no big deal when it's a big deal. You must identify those parameters. Sometimes we have what's called a QS wave. What that means is we have our P wave, we have our PR segment, and then we have a down-going deflection. Is it a Q wave? And then we come back down, and we go up, we go right back to baseline, and we go into our ST segment, and we go to our T wave. So we think to ourselves, is it a Q wave? We have no upward deflection at all. So is it a Q wave or is it an S wave? Well, we call it a QS wave. Okay? Because we don't have an R that's in between. We don't have an upward deflection, we just have this downward deflection. And so nomenclature for that would be a QS wave. So QS waves can be normal in V1. So think about V1. Remember V1, our precordial leads is going to have maybe a little bit of an R wave, usually not much, but it's going to have that big S wave. Okay? So you may only have a QS wave in V1, and that would be considered normal. But outside of V1, it gets concerning that they're either ischemia or infarcting, if we have that persistent QS wave outside of V1. So here we have an EKG that shows a QS wave in V1. That's okay. But look, that QS wave extends to V2, it extends to V3, it extends to V4. That is concerning that this patient is infarct. Why do we have this continued extension of that QS wave? We've got our R wave. R wave represents depolarization of the ventricular ABC. And it's going to be our first positive deflection after our P wave. We don't always see an R wave, but the majority of times we will see an R wave. In our QS complex, it's going to be your only positive wave that's normal. Certainly you can have an R prime, but we're talking about a normal ECG, a normal QRS complex. Okay, amplitudes of those R waves, they're going to vary from lead to lead. They vary from lead to lead. Typically V5, V6, we're talking about amplitudes upwards in the 20s, 20, 25, but usually less than 26. When we think about hypertrophy, we actually add the amplitude of the S wave with the amplitude of the R wave and V5 or V6 in 1 and 2, and that should be less than 35 millimeters. So we don't have to memorize that now. We'll talk about that a little bit later. We'll talk about hypertrophy. Okay. AVL should be less than 12 meters. What does it signify if you have really high amplitude R waves? Hypertrophy. Something is going on that heart, that ventricle is super musculature and is pulling a ton of electrical conduction its way. And we're going to see that as going to be represented on how high the amplitude is in those R waves. Okay. Leads 2, 3, 1, 2, and 3, we typically have the lower amplitude just by placement of the ECG leads. And we already talked about RR prime. We already talked about our precordial leads, and we know that in our precordial leads, yes, in D1 you could have a QS. You might have a little tiny R, but you're going to have a big S. And as we progress, the R to S wave progression from V1 to V6, V5 and V6 are going to be the meat of that left ventricle. And yes, we like the right ventricle, and we need the right ventricle. The left ventricle is really what we're seeing with this. It's really telling us what's going on with the heart. So V5 is directly over the left ventricle. V6, bless you, is just a little bit higher. And so typically we'll see that V5 has a little bit higher amplitude than V6, but oftentimes just about the same, maybe a box or two different. But look at that S wave, hardly any S wave here or here. Here, we can look through this ECG and just see the differences in the amplitudes from lead to lead to lead. And there's no lead that you can say, oh yeah, 1 and 2 should be the exact same, 2 and 3 should be the exact same, 2, 3, and AVS should be the exact same because they look at the inferior portion. No, they're going to be different from lead to lead to lead. And once we talk about hypertrophy, I will tell you some keys on how to remember and what the things that you need to remember to really identify hypertrophy. Otherwise, you don't have to really focus on how many boxes high each one of these are. You need to know how to count them like we did at the very beginning. We got that S wave, depolarization of the ventricular basis. It's going to be your first negative deflection after the R wave. Not always present. We don't always see that S wave. Sometimes that the depolarization of the ventricular basis is still occurring, but it's kind of enveloped in that R wave, especially if you have a wider complex R wave or a wider complex QRS. And we can still, just like we see with RR prime, you can see S prime as well. If we have something going on up on the ventricular basis where that depolarization is a little bit different. That QRS complex, that's the only complex that we have in our ECG. Only complex we have is our QRS complex. And that's going to be located after the P wave, after the PR segment. That represents depolarization through the entirety of the ventricles. So we've got the ventricular septum, we've got the ventricular apices, and we have the ventricular bases are all in that QRS complex. And remember that Q wave, we may not see it, but if we see it, we've got to figure out, is it significant or insignificant? Is it pathologic or not? Should we be concerned about it or not? Okay. R wave is that first upward deflection, and then that S wave is going to be any negative deflection after the R wave. Okay. We've got lots of QRS complexes here all throughout, and we should be able to see those QRS complexes. All right, let's take a break, and then we will continue on. Beginning of the Q wave to the end of the S wave. Remember, we may not see all three boxes. The duration of that complex, whether it's just the R and the S, or it's a Q and the R and the S, or the Q and the S, that complex, the duration can be up to 0.12 seconds. Okay, 1 to 3 small boxes. If it is greater than, so actually 0.119999, if it's equal to or greater than 3 boxes, 0.12, that's considered wide. That's a wide complex QRS. Right? And there's a lot of things that can cause wide complex QRS, and a lot of them are bad. Okay, so we'll talk about wide complex QRS, but greater than 3 boxes is considered a wide complex QRS. And what is causing this QRS complex is depolarization of the ventricles to be extended, because that's what we're looking at, right? Depolarization of the ventricle. The amplitude, again, can vary from lead to lead, but typically not more than about 35. Okay? Typically between 5 and 35 millimeters in amplitude, in that voltage. And that's where we're going to count the boxes from the baseline to the top of that, usually that R wave, right? Because we're going up. Normally, for the deflection of that QRS, now when we talk about deflection of the QRS complex, we're talking about the main portion of the QRS complex. So usually, in most of the leads, we're going to have a prominent R wave and a smaller S wave, right? Except for in V1 and V2. But the main portion of that QRS complex is typically the R wave, is typically be positive in the majority of leads. 1, 2, 3, AVL, AVF, V4 to V6. Okay? It can be more negative in those early precordial leads, V1, V2, V3. Okay, meaning, if I say in V1 that the QRS complex is more negative, what am I really referring to? What component of that QRS complex? The S wave. Okay, the S wave. Because the R wave is going to be positive, and typically in V1, V2, and around V3 we start to get that transition. V1 and V2, we have what? A prominent S wave. Small r, prominent S. So in V1, V2, and then sometimes V3, we will see that QRS complex, the complex itself being more negative because we have a prominent S wave. So that's what I want you to understand. It's hard to kind of visualize that, but look at all the other leads. We've got our P, we've got our PR segment, we've got our R, and we come down a little bit of an S. So that's more positive. There's more going above baseline than there is going below baseline. Okay? When we look at V1, V2, we've got our P, we've got our PR segment, we go up a little bit, and we go down for S, meaning they have more, it's more negative than it is positive because that S wave is more prominent. And so that's more of a negative. The majority of these leads are going to be more positive. They're going to be more above the baseline than they are below the baseline. Because this is associated with a lot of electricity that's being generated, that's why we have that quick up and quick down. Okay? When we have wider QRS complexes, there's something going on with the amount of energy that is being exhibited. And it's going to change the width of that QRS complex. It's going to get longer, or you can have really, really narrow as well if you have even more or quicker depolarization occurring. Y'all know, understand history. Has anybody heard of the bread revolt? Anybody? Okay, let's, it's because it was well before, even before my time, I think, 1863. 1863, there was multiple of these bread revolts. And it happened in, this one happened in Mobile, Alabama. It happened in Richmond, Virginia as well in April of that same year. And what happened is these women, they show up at the grocery store and they're like, these prices are too high. You don't have enough food in the grocery store. We need to do something about it. And they were, I mean, even the 1800s women will be sassy, right? They show up at the store and like, we don't like it. And they're revolting. They're revolting and they want to get their bread and they want to get their products. So they had, I didn't know there was such a thing to put on the history books as a bread revolt. So there we go. First Labor Day, Labor Day's just passed, so first Labor Day. So first Labor Day is the first what of the month. So is Labor Day always on the same day? No, it's on, usually it's on my birthday weekend. So this year's not my birthday weekend, so I have 3 days off. in the world going on here. And so anyway, Labor Day, first Labor Day parade was held in what city? New York City. How do you know that?
That really happened.
Yeah. Okay, Muhammad Ali, also known as, what's his name? What's his real name? Cassius Clay wins the Olympic gold in 1960 in Rome. Okay, that was actually kind of the very beginning of his career. And then in 1976, by Jim Hendrix, is The Muppet Show. The Muppet Show. Do y'all even remember The Muppet Show? Or if you have kids, maybe the Muppet movies. Okay, so let me hear who are some people on The Muppet Show? Kermit?
Piggy.
Who's Peggy?
Fozzie.
Fozzie? Oscar? Cookie Monster? Elmo? Oh my gosh! So many. Gonzo?
Gonzo,
Right?
that's one.
So many. Animal? Remember Animal? He's always so grumpy about everything. So many. And then we got Count. Count Von Count. That's his name. Remember? My son's
They had a penguin too.
Miss Piggy. What was some of the, what did she refer to herself as? Y'all really do not remember. Moi. Moi. Because she always felt like, she loved Kermit to death, and she all did Kermit. But she felt like, she was the top of the world. And she was the most important thing. She referred to herself as moi. And then she often did this, hi-ya. And what was that reference to? Karate chop. Hi-ya. It's okay. I forgive you guys. You guys are young. Okay. We have the J point. Okay. The J point is the point between the QRS complex and the beginning of that ST segment. Okay. And the J point is really important because this is the area that we're looking at to tell us if the ST segment is elevated, so above baseline, or if our ST segment is depressed below baseline. We have different J points that we might see. Okay, so this first one, that's our normal J point. We've got our P, we've got a nice little Q, R, S comes out here, we come up. We have a great transition from our J point right into our ST segment that's flat, that goes along with our baseline, looks perfect. Okay. What about this J point? What would we say about this J point?
Elevated.
Probably elevated, right? Because our baseline's here, our J point is way up here. So that would be considered elevated. So we have our P, we have our Q, we have our R, and the thing is this is still our S, but because our J point is elevated, it looks like our S is elevated as well. It's kind of pulling it up. This is it's still, but you can still see kind of, between the end of that S and the beginning of that ST. This J point is elevated as well, but it's more of a smoother transition. You don't really see a distinct point where we go from the end of that QRS complex into that ST segment. So it's kind of coming down and rounding up into that ST segment. Okay, this J point then would be considered depressed. Okay, depressed J point. And then this one, we've got a J point, which is elevated, but we also have something called a J wave. A J wave. Have y'all heard about the J wave? No. J wave, also known as the Osborne wave. And I will tell you, in my 25 years in emergency medicine, I've probably seen this 5 times, and probably once in primary care, and it was just happened to be a flu because I had no idea what it was. I did not even remember being taught this. So you're not going to see this very often, but if you see it, you want to think about things like something wrong with the electrolytes, like calcium, a severe hypothermia. So older person or even younger person found down, okay, they're unconscious, so they can't tell you anything. You do an EKG on them, and you see this J wave, you better get a core temp on them. You better get some labs on them, because that's an indication of something going awry. Most of the time we can see it diffusely, but a lot of times we'll see it in B3 or B6 and sometimes in those inferior leads more prominently. Again, hypothermia, hypercalcemia, but the times that I have seen it twice in hypercalcemia, but I've seen it in subarachnoids. Subarachnoid hemorrhage, this person comes in, they're still walkie-talkie, but something wasn't quite right. So on the EKG, I was able to see it on the EKG. What we're looking for, and again, oftentimes this is super subtle, okay? It's one of those you just have to have in your differential when you're looking at these ECGs. Okay, but we're looking after our QRS complex, we should go QRS, come back to baseline and go into our ST segment. But it kind of strap hangs on the back of that QRS complex. We have a little bit of a round area, a little bit of a point area where it looks like it's associated with that, but it's definitely different. You've got a line between that. So here's a little bit of a J wave here, okay, a little bit of a J wave here. You don't really see it here. I mean, I can see it because it kind of pokes in, and then not really much here, but that's a J wave. And then here, would you agree that you can maybe see it a little bit more prominently on this EKG? Okay, we've got a J wave right here. So we've got this, we've got our P, we've got our Q, R. Okay, we don't really come back down to baseline, so we've got an elevated J point, but also on top of that, we've got this thing that kind of strap hangs on the back of that QRS complex. We see it here, we see it here, we see it here. Okay? We also see it over here in our lateral leads, right here and right here. So hypercalcemia, hypothermia, intracerebral hemorrhage would cause a J wave. At STs, yes sir? So R prime is one that's not going to be that low down. Okay? This is really, you are finished with that QRS complex, and now this is something hanging on to the bottom. So R prime is going to come up, it may come down a little bit, but then it's going to go right back up. This is just like a little thing, and R prime is still, because it's still an R wave and still ventricular depolarizations, you're still typically going to see that sharp up, sharp down, as opposed to very more smooth. ST segment, the time between, represents the time between ventricular depolarization and repolarization. Okay. This is the time that the ventricles are going to use to maintain that contraction and then push that blood out of the bottom of the ventricle, out to the body. Okay. And our ST segment, for measuring purposes, is going to be the end of that QRS complex, where that J point is at, to the beginning of our T wave. Normally, we want that ST segment to be at baseline, meaning it aligns with our PR segment. Okay? You can have a little bit of elevation, you can have a little bit of depression, you can still be within normal range, but if we have greater than 2 millimeters of elevation or 2 millimeters of depression, which is 2 small boxes, that is concerning for infarct. And this may be an infarct that is occurring in the last 10 or 15 minutes. So that means if you see it, repeat that EKG in 15 or 20 minutes and see where your ST segment is at now. And this might be the very beginning, but certainly if you have elevation or depression, that is concerning for infarct or ischemia. So elevated in myocardial infarction, that's greater than 2 millimeters in those 2 contiguous leads. Okay? We can also see elevation in benign or early repolarization. Dr. DeBoer will talk to you guys a little bit more about benign early repolarization. That's going to be seen typically in very young, healthy people, very thin. And so when we're doing ECGs on them, the electrodes are really close to the heart, and we have this reverberation, and so you can have that increase in your ST segment. Okay. If we see diffuse ST segment elevation, we think about something like pericarditis. We're seeing a whole bunch of leads. We can see depression of that, so it's going to go down below baseline. That's usually ischemia. So we have decrease in oxygenation, decrease in blood supply to a certain area. We can also see an abundobranch block, which we'll talk about how to recognize that, and then ventricular hypertrophy. We'll talk about how to recognize that. T wave is going to be our last normal wave. Last wave on a normal ECG. P, QRS, T. That's gonna be the last one. And that is typically an upright deflection, represents repolarization of those ventricles, bless you. The amplitude for that T wave, so typically less than 5 millimeters or one large box in our limb leads, and less than 10 in our chest lead. You gotta know that. You gotta know that. Because there are things that will make those T waves look really high, and those things that make those T waves look really, really small. Less than greater than 10 millimeters. Okay. Most of the time, when we look at that T wave, we expect it to be asymmetric. Asymmetric, not symmetrical. Matter of fact, if it's symmetrical, we get more concerned. It should be a gradual up and then a sharper down. Gradual up and sharper down. Okay. And again, it's round in shape because it requires, it's repolarization. It doesn't really require a lot of electroactivity to repolarize the heart. There are lots of things that can affect the T wave. Tall and peak. We think about myocardial infarction. We think about hyperkalemia. Hyperkalemia. Okay? And it looks like it's kind of like you took that T wave and you just pulled it up to a point. But sometimes when you're looking at the T waves, you're like, man, that looks really big. Look at your amplitude. Is it greater than 5 boxes in the limb leads? Greater than 10? Because if it's not, it's still a normal T wave. Okay, they can be inverted. Okay, sometimes in D1 that's normal. And the reason why is because it's following the primary component of the QRS complex. So again, V1 is primarily negative because we have a prominent S wave in V1. A lot of times the T wave will follow the primary component of the QRS complex. Does that make sense? So in other words, if you have a normal QRS complex, P, Q goes down a little bit, R is big, S is a little bit. T wave should be upward. Okay? But if you have a P and your Q goes down, R is a little bit, S is deeper than that R wave is above the baseline, that's what wave goes deeper, then your T wave will often follow that deeper component or the taller component, depending on which one is more prominent. Okay. If we see generalized inverted, that's considered, we think about pericarditis, we got to think about what the patient's complaining of. V5, V6, ABL, we might see a little LVH or bundle branch block. Okay, so different abnormalities in that T wave will represent different things. If we have flattened T waves, okay, so they're real flat, hypokalemia could be the cause. If they're infarcting, that could be the cause, or if they have ischemia. Okay, if they look elongated, so they're really long, or they're straight, they go symmetric, up and down. We think about a stroke, could be a hemorrhagic stroke, could be a ischemic stroke, and that could be the cause. So I had a patient that came into me not that long ago from physical therapy. She was like 75, had a history of hypertension, but was like on low dose lisinopril or something. But they brought her into EMS because she was at physical therapy. She was finishing her physical therapy, which she self-reports was kind of stressful, but she went to stand up, she felt dizzy. And so they bring her in, and she looks okay, blood pressure is okay, pulse is fine, everything looks fine. But she has a little bit of dizziness, but otherwise she's feeling okay. So we do this entire workup on her, do the EKG, do a cardiac workup on her, and everything looks okay. But then the nurse comes out and says, she's vomiting. Why is she vomiting? I don't know. So I go and talk to her, so how do you feel? I feel okay. I just felt a little nauseous, but I feel okay now. Okay. So I'm waiting for more labs to come back. Nurse comes back out. She's dizzy and vomiting again. I go in them. Now she's sitting in the bed. And how do you feel? I feel fine. I feel okay. No headache, no this. No, I feel okay. Well, you were just dizzy and vomiting. Yeah, I don't know. I mean, it's crazy. I got up to go to the bathroom, and then when I got up to go to the bathroom, I felt dizzy and vomiting. So I'm thinking, I'm like, what in the heck is going on with this lady, right? And I know she's got to come in, but I just can't figure out why. And so I actually called internal medicine, and I'm on the phone and I'm like, there's something going on with this lady, and I cannot figure out what it is. And then the light bulb went off, and I said, look at this EKG. And on her EKG, she had like this diffuse T wave inversions, even though troponin was negative. And I said, I'll call you back. I spun her head, she had a cerebral infarct. Cerebral infarct, meaning all the way down here, okay, cerebellar infarct, so all the way down here, cerebellar infarct. And so she was fine as long as she was sitting down. But as soon as she stood up, because cerebellum does your balance, right? As soon as she stood up is when she feel off balance and then vomit from that. So, never mind, I don't need you, I need neurosurgery. Right? But ultimately, there's nothing you can do about cerebellar infarct. She came to the hospital, she did okay. But it was very slight changes on the ECG, and I was like, oh. But she was coming in anyway, but I just had to try to figure out what to do. So sometimes you look at that. If they're not complaining of chest pain, okay, and they don't have a lot of comorbidities, expand your differential. Something you guys are learning in junior clinical court. Expand that differential. Does it make sense? And you got to expand your differential. All right. We've got to know about the QT interval. QT interval starts at the beginning of that QRS complex and goes all the way to the end of the T wave. What if there's no Q wave? It's still called the QT interval. It's the beginning of your QRS complex. Whether you have a Q wave or not, it's still called the QT interval, and it's going to begin at the beginning of that complex. If that complex is a QS wave, it's going to begin at that. If the complex is only an R wave, that's where we start. So at the very end of that PR segment, or the end of that PR interval, we're going to start our QT interval. And the QT interval is going to vary depending on the patient's age, depending on their heart rate. So oftentimes we use, to identify the QT interval, we use what's called the corrected QT, and that's going to be spit out by our computer, which is really, really nice. Meaning you don't need to memorize this formula, okay? Because I don't even know this formula. I just look and tell me what the computer says. I do believe that about the computer. I don't believe a lot of things that the computer says, but that's one thing I do. So, but you do need to know what is normal. So QTC, that corrected QTC for males, 350 to 450 milliseconds. Females, 360 to 460 milliseconds. Because that's roughly 9 to 13 small boxes. Rule of thumb is that QT should be less than half of your R to R interval. So we've got a peak of one R, we've got a peak to the very next R. Measure that QT with your calipers, put it up in between those two R's. It should be less than half of the half, oh my Lord, less than half of the R to R interval. Does that make sense? Okay, if you don't have calipers, count your boxes. How many boxes do I have in between these R to R? How many boxes is my QT? Should be less than half of that. Okay. And it's important because prolonged QT can lead to death. And it can lead to death quickly. It can lead to something like a torsade. Because what is happening is, when you have a prolonged QT, we're going to have a delay in repolarization. Something causing a delay in repolarization. So part of the heart has repolarized and is now getting to depolarize. And the other part of it is still trying to repolarize. And they meet in the middle, and the heart goes crazy. The heart's like, what do I do? And so then it stops and can put these patients into a fatal arrhythmia, something like a torsade, VTAC. VTAC often goes into VFib, and VFib goes into death, right? So some people are born with a prolonged QT. That's how they're born. Some people are on medications that can cause a prolonged QT. You guys remember from forms and common medications? Okay, anything that is an anti in it can prolong QT. Antiemetic, antidepressant. People with electrolyte derangements can have a prolonged QT. Okay, some people can have a short QT. They can be born with short QT syndrome. It's important to know that most of these people are not going to be in the military, but some of them will slide in. And we got to be really cautious. So, especially in older people, we be really cautious by giving them two prolonged QT prolonging medication. For example, someone comes in and they have a UTI. We'll give them ciprofloxacin, and they're nauseous, we'll give them an antibiotic. Antibiotic, antiemetic means double trouble, right? Prolong that QT. Does that mean that I get an EKG on everybody I give an antibiotic to or an antiemetic to? No. But I do try not to give them two QT prolonging medication. Okay, so again, short QT, hyper-K, hyperkalemia, hypercalcemia, could be a short QT syndrome, or even something like WPW. Can have a short PR, can have a short QT as well. This increases a risk for things like atrial fibrillation, VFib, VTAC, both prolonged and shortened QT. So here we have a normal QT from the beginning of the, remember, look here, it doesn't have a Q, but we're still in that same complex. From the beginning of the QRS complex all the way to the end of the T, normal. Here, if we count the boxes, prolonged. This is this is actually about almost 500 for the QT. Okay? And although I would be okay with 500, that's not normal. And we got to look and see why is your QT so long. Okay. So this is an indication of prolonged QT right here. We've got all the way to the end of the Q or into the T. That's about 5, 10, 15. Okay, and if you do that, or maybe about 12 or so, you times that times 0.4. I know math, but I'm not going to ask you to do math. I'm going to tell you that is prolonged. And you can look at it and say, man, that looks like that's way out there. That reach way on the other side for the end of that T wave. Right? So this is a prolonged QT. But you need to know those parameters. You need to know those numbers for males and females, which are slightly different. This is a short QT. You can see that it also looks like we probably have a short PR interval there. We don't have much of a PR segment at all. And then from the beginning of this QRS complex to the end of that T is a little bit shorter than what we would expect. When you look at the milliseconds, that would we expect this to be. And then this is V4, V5, V6. What do you think about them T waves? We count 5, and even the T waves look a little bit peaked on that. So we got short QT along with some peaked T waves, which we concern. Other intervals that you need to know are interval. That's from the top of one arm to the top of the next R. Okay, that's an R interval. We usually use that for to help us determine rate and rhythm. We look at the top of those R waves. Are they in rhythm? Or are they both? Okay, we can do that from R to R to R. We should be able to take our calipers on one arm, okay, and then we leave it on the next, and then we swing it to the next, and then we swing it to the next. We shouldn't have to move those calipers. That's how much of R waves should be for a normal, a regular rhythm. Okay? We use that to determine QT. And that's how the machine uses it, to determine that QTC. Okay, and then P to P, to our P wave to our P wave. Oftentimes we're going to use that to determine things like an AV block. Okay, what is going on between the atrial and ventricles that's blocking? Why are there P waves? They should be going right in order. They should be one P wave to another. Same thing. Put your calipers on one P to the next. They should march out. And if they're not marching out, something is wrong. Something is causing it. You're not getting a good electric conduction from your atria down to the ventricles for some reason. At least not consistent. U waves. We don't see U waves very often. Okay, if you see it, and you can't really tell on this, okay, but if you see it, it's going to be between the T and the P. Now the P would be over here. If this is all you saw, I would not blame you for saying, wait, how do I know that's not a P wave? You can't see the P wave because it's off of this piece of paper. And between the T In the P wave, we should have T comes down to baseline. We should have a little bit of a rest, and then we have that P wave that starts back up. If you have another upward deflection between that T and that P, that is a U wave. Hypokalemia, hypocalcemia, dig tox. We don't see a lot of people on digoxin anymore, okay? But if you're in a position that you're going to, especially Reserve and National Guard folks, you might be seeing older patients that are still on dig. And if you do, that's an indication of detox. So this is some U waves. So we have a normal ECG here where our P, QRS, T. We come over here, we've got our P, QRS, T. We've got kind of a flat line between our P. But here we have our P, QRS, T. Our other P is over here. It's right next to our QRS. We shouldn't have all this space between them. We've got something, some upward deflection between our T and our P. And that upward deflection could indicate a U wave. We've got to get labs on these people. Got to see what's going on to see, make sure. Now, could that be a normal variant? It could be, but you can't say that without some labs to prove that they do not have an electrolyte arrangement. So if you don't have the capability to do labs, they've got to go somewhere they can do labs. All right, this is just a summary slide of the normal ranges that you probably need to review. Okay, let's see, a couple of review questions and then we will finish up. Brags. Yes, ma'am. Okay. What cardiac event is represented by the T wave? Ventricular repolarization. Okay. Does everybody agree with that? Do we have ventricular repolarization? Yeah, it's just repolarization is represented by that T wave. Repolarization of the heart. All right, very good. All right, what about, okay, you got a person that's coming in from Thailand. Anthony. Okay, ma'am. Person coming in from Thailand. Has anybody been to Thailand? How fun, I've been to Thailand. I was there over New Year's in Bangkok. Ooh, let me for you. That's a bad idea. I mean, I don't remember a lot of it, but I think it was a bad idea. Okay, we got a person coming from Thailand. She has chronic kidney disease, and she's coming with muscle weakness and difficulty breathing. She says, I also have this constipation, but I've been using this, eating this durian fruit every day. And you would say, man, I remember from freshman semester that this durian fruit has a lot of potassium in it. And she has chronic kidney disease. What might you see on the EKG that indicates some underlying pathology?
Peaked T waves that was generalized.
Peaked T, so E?
Yes.
Peaked T waves, right? Hyperkalemia. Okay, might we see anything else? YQRS. So we might also see a YQRS. Usually not narrow. Inverted T's, not often, not usually with hyperkalemia. ST segment depression, you could, but really primarily it's going to be those peak T waves, or peak T waves that we're going to see. Peak P has to do with the atria, so usually it's not affecting. Okay, and then Crier. Crier? Is that how you say it? Crier. Okay. Which component of the ECG represents ventricular depolarization? QRS, right? Ventricular, we didn't say ventricular only depolarization of apices. We didn't say depolarization of apices. We had ventricular depolarization, that's the QRS complex. Okay, and that is it. I hope y'all have a good weekend.